Okay, thank you. I am not Eric Marsh. I could never be Eric Marsh, but he was unable to come. So these are actually my slides, so if you don't like it, don't tell him. And I do not do research in this area, so I do it, I clinically treat patients with DBS, with LGS, so this is more of a perspective of a physician who takes care of these patients. I started my first patient, we put a DBS in about 5 or 6 years ago, and my first thought was my patient had been on all the meds available in the United States and outside of the country and had fallen down the stairs and broke his neck. And at that point, I was like, well, you gotta do something. So I tried it, and it worked stupendously well. But my first thought was, how the heck does a surgeon get into that little area consistently? When you look at it, I know they've shown pictures of this, but that is a tiny little spot. And I was suspicious that that was not going to succeed, but it has. In fact, it's not been an issue at all. And I read through the literature at the time that existed, which was not very much, but the idea was that the Centromedian nucleus had this effect on seizure control in patients with Lennox-Gastaut. This is older data, but I think actually my clinical impression is that the research studies sort of do mimic what I see in my patients. So what you first see is that there was a pretty profound decrease in generalized seizures, but not really in focal seizures if you implant the Centromedian nucleus. And that has been my experience. I have patients who have a mixture of seizure types, and it's very good for their generalized seizures, but not really for their focal seizures. Seizure freedom has occurred in some of my patients, but not sustained. And when I say that, I mean that certain seizure types have pretty much abated, such as the absence seizures and tonic-clonic seizures, if they, I'll talk about this in a minute. I use a device that is has like a battery that's rechargeable. So I have little experiments where my patients who are teenagers, some of them decided not to recharge their battery, and lo and behold, their seizures come back with a vengeance. So internal controls suggest that they can be seizure-free if they continue to charge their device. So I would say that my data is fairly similar to these two studies. There is a good response to tonic absences, and I think atypical absences are particularly responsive to these devices. There was not major shifts in this study in anxiety behavior, but there was an improvement in quality of life, and I definitely hear from my families that there is an improvement in quality of life. And some of my patients who previously would not have been able to tell me they had an improvement in their quality of life do. So I think there is something rather profound about this device, or this concept of neuromodulation of the Centromedian nucleus. This study has been discussed pretty extensively. So I may defer some of this discussion, but you briefly saw the trial design. And the interesting part about it, I think, is that when you place the device, you get an effect, or at least that's been my experience. Some of the patients have a pretty profound decrease in seizures just from implantation, irrespective of how you do the neuromodulation. So that complicates things, because if you're sticking the device in, but then, not stimulating everyone, but eventually stimulating everyone, if you get an effect of just the implantation, it kind of makes the data more challenging to interpret. Personal opinion. Here is some of that data, and that's kind of what I mean by this idea of some effect of just implantation. So what you can see here is that if you do the implantation, it maybe doesn't mean that you need to turn on the stimulator to get some effect, but then when you do turn on the stimulator, you can augment that effect. Does that make sense? So Basically, in this blinded period, you see there is a split between the early turning on of the device and later turning on of the device. But when you start to turn everyone on, they do seem to get a benefit. So it's this complicated situation where, like Dr. Morell talked about, it takes time, and then maybe just implantation does something. So it's really hard to think about how to do a study. So I was very impressed. That sounds like a very cool way to think about the study. But you do see that the majority of patients get a benefit. There are other non-seizure outcomes that are mentioned in the paper, and I hope I do this justice, but there was a report of improved alertness in most of the participants, and then the caregivers were asked questions about how they perceive the overall differences, and there was a good sense that there was improvement in alertness, and the caregivers reported that most of the patients were better off. And they pointed out one patient who had a very profound reduction in their seizures, but yet really wasn't, quotes, better. And this comes back to this idea of, if you're still having one drop seizure a day, is that better? So I think everybody would have a different perspective on that. Side effects. So there were many adverse events reported, but they were relatively mild. But 3 patients had this post-operative brain edema with sedation, and that required a prolonged hospital stay. And we have had one patient with this. I do not know what causes it. I do not know what to do about it. We just sat there and watched the patient for like 11 days, and he got better. But we were hesitant to give them steroids due to the risk of infection, so maybe would have got better quicker. We have had they did have a patient that got an infection and then the device had to be removed, and that has happened as well to us. The patients complained of tingling or sensory changes, though all were transient, and there was some decrease in appetite in some of the patients. So I'm going to tell you from a very practical standpoint what I do, and you can take it or leave it. Remembering that I just did this out of desperation in one patient, and he became seizure-free for over 18 months, where he had had hundreds of seizures a day. So that was pretty profound. Like, I was like, oh, this is a home run. Well, it's not always a home run. But I just decided, after reviewing all the different devices available, that we were going to try the Boston Scientific because it was rechargeable. And in my head, that seemed like a great idea. You know, you won't have a battery change, you'll recharge it. And it has been a great idea in some patients. However, teenagers don't always do what they're supposed to do, as you recall. So remembering to charge it about once every 2 weeks does not always happen. Another question that I was curious about was, will I have difficulties with insurance covering the device? And so far that has not been the case. And then I thought I would have trouble finding a surgeon to hit that little tiny nucleus, but they have been 100% accurate, and we've used 3 different surgeons over time, and there has not been an issue with that. So kudos to the surgeons. So what settings do you use? I had no idea when I started, so I went back to the literature, and I used the settings that were originally used in like the early 2010s, 15s, and those didn't work as well. So these are the settings that I have, through much trial and error, come to settle on. But it's really hard to know because, like, you know, if you just keep changing things, like, how long do you wait before you change something? Good question. I would love to know what people think. The other thing I've discovered is higher is not better. So somehow I was like, all right, if 3 milliamps is good, 5 should be kicking. Well, no, that's not true. So I sense there is some middle ground. The other thing is, I was super anxious about adjusting things because the patients would be like, oh, I feel that in my tongue, I feel it in my mouth, I feel it in my hands, and I would be like, I gotta turn it on. Well, if you just wait about 5 minutes, it goes away. But the first few patients, I was just a nervous wreck when I was adjusting things, and they would complain of something, and I would be like, So my overall impression, not scientific, is that it is very good for atypical absences. It's pretty good for tonic-clonic and atonic seizures, but it has not worked for one of my patients who has a clear focal frontal lobe, bifrontal, independent frontal lobe seizures. So these are all things I wish I knew. Which patients benefit and why? Do we jump to DBS before VNS? Every single patient we've implanted has had a VNS, and we have left the VNS alone. We've just said, you have a VNS, congratulations. We're putting a DBS in. But we are discussing at surgery conference pretty consistently, is that the right thing to do? Should we just go to a DBS? Is it important to have a VNS? All those things. With settings, I sometimes spend way too much time fiddling with settings, I suspect. And then why do a few patients get this brain edema? And then a shout out to Juliet, who is here. She's writing up our patient experience as it stands, which is not scientific. It's strictly just case reports. So thank you.